So, good morning, everybody. I would like to welcome you to our joint webinar, European Society of Emergency Medicine and the ERC. My name is Wilhelm Behrens. I am a professor of emergency medicine and have a lot of echo now. Okay, now it works. I am professor of emergency medicine and chair of the emergency department in the Vienna General Hospital, Austria. And I'm also the secretary of the European Society of Emergency Medicine. And I will hand over to the next moderator. Anastasia, please introduce yourself. You have to unmute yourself. You have to unmute.
Thank you. Hello there. I'm Anastasia Spartinou. I come from Heraklion, Greece. I'm an emergency medicine physician and also a young ERC social media representative. And I'm really happy to meet you all today. Unfortunately, virtually, but really happy to be here and discuss with you. And I now give the floor to Dr. Abdu.
Yeah, thank you, Anastasia. Good morning, everyone. And very happy to be here in this joint session between ERC and EUSEM. I'm Abdou Kouri. I'm from France, from Besançon. I'm a emergency physician also, and actually I'm the president of the European Society for Emergency Medicine. So I have the pleasure to co-chair this session with Professor Beringer and Dr. Spartinou. And unfortunately, we were planned to have 4 speakers this morning, but Dr. Cassie Hampton, who's actually deployed in Ukraine, cannot make it because she has a very poor connection, and she's really sorry for that. So we're going to have only 3 presentations. And I will start with Dr. Alice Hutin from Paris, from the SAMU of Paris, EMS Services. She's one of the leaders in the world of ECPR, and she's a very good emergency physician and a close friend to us. And so I'm very happy to have her here, Alice. So please, the floor is yours.
Thank you, Abdul, for this very kind introduction. Hello, everyone. Hold on, I'll try to share my screen. Is it okay for everyone? Yep. So yes, hello. Thank you very much for having me here. The idea is that we're going to talk a little bit about refractory cardiac arrest. And the question that was asked to me was, should we bring ECPR to the patient or should we bring the patient to ECPR? ECPR has been a very popular subject in the past few months and years. And this is a real question that is important to us on a day-to-day basis. So just to make sure we are all, we all have the same thing in mind, ECPR is veno-arterial extracorporeal circulation that is implemented to the patient during CPR after failure of conventional CPR, sort of as a second line of therapy to make sure that some patients who are eligible have a second chance once conventional CPR has failed. So basically, this is something that has been introduced into the guidelines for the past couple of years as something that we should consider after failure of conventional CPR. And these past few months, we've actually gone from something that we are supposed to consider to the question that ECPR is maybe now something that should be a new standard of care. If this is so, we need to organize our systems of care to make sure that patients who are eligible to ECPR can be treated within the right time, that the right patients are treated. And in this sense, we need to organize things to make sure that the patients have it in time. And this is important in the sense that we need to organize out-of-hospital cardiac arrest management to make sure that ECPR is given to the patient. And this is where the question of transportation of the patient comes into place. And the question that is asked, should we bring ECPR to the patient or the patient to ECPR? And this is something that you need to anticipate, and we're going to come back to this because you can't just decide on one day that a patient that is eligible to ECPR needs it, and you cannot just decide on the scene how to make things work. So just to put things into perspective, it's very important to keep in mind that patients who will be treated and who will benefit from ECPR are patients who need optimal chain of survival management. So these patients need to be early recognized in cardiac arrest. They need to have bystander CPR. Sometimes we can help them with community response. We need optimal BLS and advanced life support. And we need to ask ourselves very early if these patients are eCPR candidates, because as we're going to see, it is a permanent race against time. So in the past few years, we've made a lot of progress trying to define which patients are eligible to eCPR. And you can see here that the latest guidelines from ELSO, unfortunately, all patients are not eligible to eCPR, and you need to sort of select the patients that have a chance of neurologically intact survival. So we've made a lot of progress in that sense. We've also made progress knowing that there is a very precise time in which we can implement eCPR to make sure that patients survive. And we know now that we have to have this treatment delivered within 60 minutes of cardiac arrest. And this is very intense when you, for those of you who are familiar with out of hospital care, 60 minutes can seem like a long duration, but it's really a race against time. And basically, we know that bringing patients in hospital for eCPR in the hospital is not as simple as it can seem. And really, we realized this in Paris, but probably all of you in Europe as well realize that distance is not always the only problem. And you can see here that in Paris, for example, trying to take a patient out of one of these buildings can take time. And it's not always simple to go to race down the staircase, especially with a patient under mechanical CPR. So deciding to run to the hospital, to have the patient in the hospital for eCPR is really not as simple as it seems. And as you can see here, sometimes we need to take the patient out the window. Then we've got basically a lot of traffic. And I'm sure that's not only something that we go through in Paris. So basically, it's really not as simple as you would think it is. And beyond that, sorry, you need to keep in mind that you need, although you are racing to the hospital, you need to make sure that your patient is getting high quality CPR during transportation, because sometimes it's not very long, but in some settings, you can be in a situation where you have 15, 20, 30 minutes of transportation. And you need to make sure that during this time, your patient is getting optimal CPR. So you need to make sure that the patient is getting mechanical CPR. You do need to make sure that the ventilation, and we're going to be talking about that with Abdul later, that ventilation is optimal as well during this transportation. So intubation is clearly a question. And beyond the optimal care for the patient, you also need to make sure that you are not putting your crew into some difficult situation where they are potentially in danger as well. So you need to keep that in mind as well. Basically, there are some systems in which this works very well. This is the example from Dimitri Sinopoulos in Minneapolis, and with one of the results of it was actually, sorry, the first randomized study on eCPR. And basically here, we see that patients were under eCPR within 59 minutes of cardiac arrest, which is definitely in the timeline that we aim for. The problem is here, for example, that estimated time for transport was below 30 minutes. What do we do for patients for which we know that transport is longer? Do we just exclude them from eCPR, or do we try to find another solution for these patients? This is another example that was published more recently from the Prague group, another system in which things seem to work pretty well, but this was in a randomized study as well. So we need to see if this can work elsewhere, and obviously it's not the case everywhere. This is just another example to show you that transportation itself can be quite long, and here, for example, despite a very protocolized system, it does take time to bring the patient to the hospital. And when you need to keep in mind that beyond this 53-minute here transportation time, there is time on site that you cannot bring below 10 to 15 minutes. And you also need to keep in mind that cannulation itself takes time, and you need to anticipate this when you try to organize patient care. This is another example in France, in Nancy, where despite a very strict protocol, once again, to try to limit time on site, we can see that between the first period where there was no protocol and the second period where time on scene was limited and transportation time was optimized, low flow time, was brought down to 80 minutes versus 99 minutes. But once again, we are beyond the 60 minutes that we aim for, and this is a problem. So clearly, it can work in some places, not in others, and the idea is sort of to try to organize things in the best way possible. And this is where the idea of pre-hospital came from, with the wish to sort of get rid of this transportation time and bring eCPR to the patient and make sure that you can then move the patient once eCPR has been activated. And the idea by bringing the low flow down is to try to bring the probability of survival up as much as possible. So the idea is then that you bring eCPR to the patient so that you are able after that to evacuate the patient however you need. And you have more time to bring the patient to the hospital to get further care as for patients who are cannulated in the hospital. And just to give you an idea of how this works in Paris, when we have a witness cardiac arrest of a patient who seems to be at very first sight a potential candidate for eCPR, the idea is that the dispatch center will dispatch at the same time community response with the app that we use in France, which is Sauve Life, the BLS team, the mobile ICU, which is there to deliver ALS, and the eCPR team. So all these teams are dispatched at the same time. The idea is that we are able to decide early if the patient is a candidate for eCPR and to organize things on the scene if necessary to implement eCPR in the pre-hospital setting. Always, of course, with the idea that eCPR needs to be activated within 60 minutes. So the idea with this early dispatch is, again, to ask the question early, is there an indication, and to make sure that eCPR is delivered within 60 minutes. This is just to give you an idea of how things are organized. We have a dedicated vehicle with everything that we need to bring the hospital and eCPR to the patient. These are a few examples that you might have seen in the literature. Obviously, it's not always as comfortable as the pictures that I've just shown you, and most of the time we are in an environment that is not very friendly. But the idea, once again, is to have the patient under eCPR early so that we can then try to bring the patient in the best conditions possible to the hospital. Just to give you an idea of timing, this is data that we published a few years ago, and clearly you can see here in the second period after which we implemented pre-hospital eCPR, and with the idea also that we asked ourselves very early if the patient was an eCPR candidate. And with this optimization of dispatch, early decision, and pre-hospital eCPR, you can see here that we were able to bring the time down and try to stay within the 60-minute cutoff that we all aim for. Beyond being in the 60-minute cutoff, the idea is also that with pre-hospital eCPR, you can try to deliver eCPR to patients who are too far out and too far from in-hospital eCPR centers. And this is an example of patients for which our eCPR team was dispatched outside the city of Paris with a heliborne team. And the idea here is that although we were beyond the 60-minute cutoff, we were able to have some survivors, and beyond this, you can also see here that patients who had a longer low flow obviously have some more important neurological damage, and some of them go into brain death, and become organ donors. But this is beyond the scope of this presentation. But the idea is really that you can also deliver eCPR to patients who are further out if they have indication criteria. So basically, pre-hospital eCPR is not something that is done only in Paris. It's done elsewhere in France, in Europe, in the world. And the idea is that we will be able in the years to come to compare all the data that is obtained, and it'll be very exciting to see exactly which patients can benefit from pre-hospital eCPR. So to answer the question, should we bring eCPR to the patient or the patient to eCPR? The idea is that you need to organize the system to make sure it works within 60 minutes, if possible. So that is how to answer the question. Just make it work locally within 60 minutes. And that's probably the best answer I can give to the question. Before concluding, the idea is that in the same manner that eCPR has to be at the end of an optimal chain of survival, it's also the beginning of the whole post-cardiac arrest eCPR care. And the idea is really to include eCPR in a much larger treatment bundle. And once again, this is beyond this talk, but it's very important to include, for example, probably temperature control or even hypothermia in these patients with long downtime or at least long low flow time, and of course, treatment of the cause of cardiac arrest. So to conclude, it's really something that you need to anticipate to make sure that in your system, if you have refractory cardiac arrest patients, you need to anticipate their care and make sure that eCPR works locally, whether it is in the hospital or in the pre-hospital setting. You need to insist on optimal chain of survival. In the same manner, patient selection and timing has to be optimized. And eCPR is really part of a much larger bundle of care. Thank you very much for your attention.
Okay, Alice, thank you very much for this impressive presentation. Abdu, do we have some questions on Slido?
Not yet. So if you want to ask questions, you should go to the application Slido. We got a few questions for you, Alice, but so far on the Slido, we don't have questions. So if you want to have questions, please go on the Slido and connect and ask your questions.
Abdu, may I ask without Slido? Can I ask like this?
Of course.
Oh, great.
And I know the question you're going to ask.
Oh, why do I know?
I know it.
Alice, it's really great. And in Vienna, we also do eCPR, approximately 50 patients per year. And when we do the cannulation, to make sure that the wire is in the right vessel, we use transesophageal echocardiography. So in the pre-hospital setting, how do you control for the wires being in the right vessels, or you don't control, you just do it? Or do you control it?
We actually use a hybrid surgical technique. So we do a cut down and we do the insertion with visual control of the vessels. So we don't check wire position, but I mean, we visualize the vessels. So we're pretty sure that they're in the right place. But we do the systematic reperfusion at the same time. And to make sure that the reperfusion, for example, is in the right place, once we're in the cath lab, we check the reperfusion at that time. But many teams do percutaneous insertion. And so I don't know yet how well it works in the pre-hospital setting with ultrasound. But basically, I think they do ultrasound, but not transesophageal.
Okay, and who is doing the cut down? Is the emergency physician, or you bring a surgeon with you?
No. I think at least for eCPR, it's really something that needs to be done by pre-hospital, by emergency physicians or ICU physicians. Surgeons, unfortunately, don't have the availability that we have in the pre-hospital system. So although it's a semi-surgical technique, it's only emergency physicians and ICU physicians.
Okay.
Yeah, I think Alice, also you can speak about your program of training for emergency physicians for doing these eCPRs. So maybe a few words of this program.
Yeah, thank you. Yeah, we actually have a 2-day training that we've been doing for the past 3 or 4 years, despite COVID. It's a two-day program where we have international speakers who come give their experience of eCPR, and everyone, we train our technique, of course, of the hybrid surgical, but there's also a training with ultrasound, and we have a large participation by the team in Melbourne from the Alfred Hospital, who are very specialized as well in eCPR. And we should have, we will have Dimitri Sinopoulos with us in September. So of course, if people are interested, don't hesitate to contact me.
Do you train the cut down on dead bodies or
Yes,
on
we do.
patients or?
We have a gel mannequin, but we also have a cadaver session in which we train participants to do the cut down and to visualize the vessels, because it's something that's actually very, not easy, but it's easy. For us, it's become easy to find the vessels, and it's very interesting to see that you can clearly identify the artery from the vein, and that's how we actually don't need to check a position like you said earlier, because we can really identify the vessels visually.
What is your time from starting the cut down until the machine is running?
It's around 15 minutes now. I think it's acceptable. We have a low failure rate. We've decided recently that we would pre-prime the machines, because until last year, we actually had an anesthetic nurse with us on the team who would prime the machine on the scene. And we found that we were probably losing time with this priming. So we've decided as of January to have pre-primed machines in our vehicle to sort of bring that cannulation time down and the low flow down, basically.
Okay.
Yeah,
Do we have a question?
we have a few questions. Yeah, we have a few questions. And one of the questions is, what is the long survival of cardiac arrest in Paris ECPR experience?
Our survival rate with eCPR, the last published data was around 29%, and it's pretty consistent with the literature. The thing is, we've sort of widened in the past year or two the indications, and the problem with that is that if you widen the indications, you sort of bring your survival rates down. In settings, in programs where they are very restrictive on patient selection, for example, if you only take shockable rhythms with very short no flows, and in a very strict decision making, then basically you increase your chances of having survival. But we, for example, have decided that non-shockable rhythms were also eligible to eCPR in certain circumstances where they have signs of life during CPR. But it's something that other teams don't take into account. So basically, I don't have our latest numbers. I think we're probably around 20 to 25% survival currently, but it's still a very acceptable survival rate. And a question that will be coming probably in the next couple of years is the subject of organ donation, because we've seen in the past couple of years, and we have data coming up on this hopefully in the next few months, that despite the long low flow times and the eCPR in these patients, the patients who go into brain death actually have organs and kidneys especially that are of very high quality. So these patients are eligible to organ donation, and this is probably an important aspect as well.
I'm afraid we have to move on.
Yes,
we have already 23 minutes.
Really, very quick question for you. What's the survival rate in cardiac arrest in Vienna ECPR experience? Do you have any figures?
We have the same number. Same number.
Okay. Yeah, this was the question. Okay. Thank you very much, Ali.
I hand over to Anastasia now.
Okay, so now I have I'm in the happy position to present Dr. Carlo Alberto Maggiori, who is a consultant in anesthesia and intensive care in Bologna, Italy, and he's gonna discuss about the use of Repo in non-traumatic cardiac arrest. So, Carlo, the floor is yours.
Okay, good morning, everyone. I'll try to show my slides. Okay. Okay, here you are. Can you see it?
Yes.
Okay. Well, good morning, everyone. Yes, my name is Carlo Mazzoli. I work in Bologna as a consultant anesthesiologist and intensivist. I work in the trauma ICU and also on the pre-hospital settings, so EMS and fast response car. And the next minute, I will talk about quite an unexplored field, which is the use of REBOA for NTCA, for non-traumatic cardiac arrest. I have nothing to disclose. And so the acronym REBOA, as you surely know, stands for Resuscitative Endovascular Balloon Occlusion of the Aorta. So it's a balloon in the middle of the aorta. And it was first described in 1954 during Korean War, and it was used to manage fatal bleeding during the war. And its current use in trauma is widely accepted and also for obstetric bleedings. And it has a fast learning curve and as shown by several studies is feasible also in the pre-hospital setting. So if we take a look to the aorta, we can see that we can place the balloon in 3 different zones. Well, 2 actually, because only zone 3 and zone 1 are available for treatment. So zone 3 is below renal arteries. It's used for lower extremities and pelvic bleeding. And zone 1, so the descending aorta between the left subclavian artery and the celiac trunk, it's used for traumatic cardiac arrest. So in the last ERC guidelines, the use of REBOA for special circumstances cardiac arrest, so traumatic cardiac arrest is suggested. And but if we are facing a non-traumatic cardiac arrest, well, could we use REBOA? That's the question. So going back to the goals of the ALS is, of course, to achieve the best possible outcome for patient surviving a cardiac arrest. And so we have to provide a good cerebral perfusion to guarantee a good cerebral outcome and a good and adequate cardiac perfusion to restore the circulation and do it as soon as possible. So going back to physiology. So during the resuscitation, we should maintain a good coronary perfusion pressure. And to maintain a good coronary perfusion pressure, we have to keep up the mean arterial pressure and keep down the right atrial pressure. So this is a gradient. And the REBOA aims to do that. And the literature show that the threshold of between 15 and 20 millimeters of mercury could have a good likelihood of ROSC associated. So when we talk about REBOA for non-traumatic cardiac arrest is the same as traumatic cardiac arrest. So we talk about zone 1 placement. This is a study on patients undergoing TAVI procedures, and they measure the distance, the depth of insertion of the catheter, which is between 43 and 48. Someone suggests 50 centimeters. Depends also on the position of the shaft. So back in 2017, Noah Daly, introduced the concept of using REBOA in cardiac arrest, non-traumatic cardiac arrest. And his discussion was based on 3 main points. So reducing the vascular volume that the generated cardiac output is distributed across. So during the CPR, of course, the volume generated by the heart is very low. And so he basically reduced the distribution of this blood to the subaortic trunks, and only with the REBOA we can do that. And augments myocardial and cerebral perfusion, and of course increasing the probability of return of a good quality of life for the patient. So 3 years later, Noah Daly did this nice review. And he goes more deep in physiological aspects, and he talked about increasing the left ventricle afterload. So it's like comparing the inflation of the balloon to a massive injection of adrenaline or noradrenaline, so to have a massive vasoconstriction. In fact, the REBOA counteracts the profound vasodilatation which occurred during the cardiac arrest. And of course, it increases, as we said before, the CPP, and the aortic diastolic pressure too, which is an index of coronary perfusion too. Well, the vast majority of Repo research is performed on swing models of ventricular fibrillation, and they showed a lot of hemodynamics benefits. And they were first described like 20 years ago, so quite far away. And multiple studies have shown that thoracic aortic occlusion improves, as we already said, cerebral perfusion pressure and coronary perfusion pressure, and coronary blood flow too, which is not the same as coronary perfusion pressure. And most important, the Untitled carbon dioxide, which is an index of good perfusion, and of course, the overall mortality. I repeat, on swing models, of course. And there is a substantial variance among these studies, probably due to the different time span between the VFib and the insufflation of the balloon. So recently, this study by Ali Sultan is on pig models, and was recently published that compared adrenaline versus Reboa during starting CPR. Sorry. Well, it turns out that not only the Reboa is as efficient as adrenaline in promoting growth, but it increases cerebral blood flow too, and as opposed to epi, as we said from paramedic 2 studies. So when it comes to human, we have just a few case series. This is the first one done by Braden in 2019, and showed, first of all, the feasibility of Reboa in pre-hospital setting, recording a mean time of 11 minutes to place the balloon, and 10 patients underwent the procedure with 60% of ROSC, and 30% of them showed a shockable rhythm before the procedure. And this significantly increase of entitled CO2 has been shown and has been interpreted as an effective centralization of the circulation during CPR. Okay, and that's the second case series by Levis, and reports 9 patients receiving Reboa during CPR, and all of them showed a non-shockable rhythm before procedure. So it's a kind of different sample of patients. And 2 of them achieved ROSC after 20 minutes of PEA, so pulse electrical activity. And only a small increase in cerebral oxygenation measured with NIRS technique has been observed. But this is probably due to the prolonged resuscitation time before balloon inflation. And last, we have this case here from our group. This cohort of patients underwent Reboa procedure, both in the field or once admitted to emergency department. And obviously, the time between dispatch and balloon inflation is significantly shorter for when we deploy the Reboa in pre-hospital setting, when the vast majority showing an increase in entitled CO2 equal or higher than 10 millimeters of mercury. And among those patients, we have seen a transient ROSC in every patient. Sustained ROSC was achieved only on 4 out of 11 patients. Both of them died then, and 2 of them went to organ donation. So in this narrative review, our group tried to speculate on further physiological aspects that Reboa could have in cardiac arrest, such as the restore the Windkessel effect, also known as systole, aortic systole, increase the threshold of VFib onset by stimulating the baroreceptor reflex in the carotid, and reduce the adrenaline dose by reducing the volume of distribution, which is the same, as we said before, of the circulating volume, reducing due to aortic occlusion. And when it comes to the catheter itself, it depends on the kind of the model of the catheter, but you can use it for invasive monitoring during ALS, so having continued pressure monitoring, and also inject drugs directly into the aortic arch, which could probably have a meaning also in reducing dose of medicine. So of course, everything has pitfalls and complications. This is due to the position of the balloon itself. So the problem are ischemia of the ipsilateral limb, of course, and the damage of the femoral artery. The placement, we do the placement with ultrasound, both in the pre-hospital setting and in hospital setting. And of course, the ischemia reperfusion syndrome after ROSC. Recently, there's been a study by Olsen on swing models too, and showed how post-ROSC lactates in a Reboa group were lower than in a conventional ALS group. And it's quite interesting considering the fact that we have the ischemia reperfusion syndrome. Probably the ROSC after Repo use shows a better contractility than the conventional AES probably, and also a better clearance of the lactates. And of course, this is the main problem, so delay standard ALS. So Repo should never delay or postpone standard LAS maneuver because nothing is clear yet. So we have to do what we always do, and then if we have chance, we can implement Repo. So there is an ongoing trial led by the Central Hospital in Trondheim in Norway. And we hope that it would give us some interesting answers on this topic, which is quite popular right now. So I would like to thank you all for your attention. I think that this topic will gain a lot of interest in the next years. Well, I hope. And thank you again for inviting me.
Thank you very much, Carlo. I don't see any questions in the slide for now. So I don't know if anyone from the panel has a question for
Can I ask
speaker?
a question, please?
Yes, go ahead, please.
What would you say is I mean, how would you situate Repo with regards to eCPR, for example? Because it's a question that we are having a lot of difficulty answering right now. So I don't know if you have any thoughts on that.
Yeah. Well, I'm gonna be honest, right now we do not have a eCPR program yet in Bologna. We are working on that, so that's easier for us. We can only choose Repo right now at the moment. And that's a good question. Of course, if we talk about trauma patient, the answer could be easier. Non-traumatic patient, I think that eCPR, if available, should have the biggest part. Well, in our review, we underline the fact that if you place, for example, a Repo on the pre-hospital setting, and then you are quite fast and you bring the patient to the hospital, you already have a shot in the femoral artery, okay? And you can easily switch to the CPR setting. Of course, it depends on the case. But eCPR goes first.
So my question for you both, a bit provocative. Can Repo insertion be much easier than eCPR on the ground in pre-hospital, for example?
Yeah, it all depends on training, I guess. So Dr. Rutin showed the 15 minutes to start from the cut down to the ECMO running, and we have 11 minutes from the puncture to the balloon inflation, and it's the same also in the other studies. So only 3 minutes, 4 minutes, it's the difference between a basic aortic occlusion and the ECMO and an ECMO. But I guess that if there are good answers by the Repo study, Repo for NTCA could play a role, for example, in low-income countries, developing countries, which cannot allow an eCPR program where there are not much money, and could be a good answer. For example, this is an option. So a kind of step between conventional ALS and eCPR, but everything is unexplored.
William?
You do the insertion with cannulation, right? Not the cut down.
No. So
how can you be like, it's the same question with eCPR because you have to be in the right vessel. So how do you ensure you're in the right vessel in the pre-hospital setting?
Okay, this is a big issue because during cardiac arrest, both the femoral vein and the femoral artery could collapse when you push the probe. So that's a good question. So we use anatomy, so the lateral vessels. I know this is a 100% chance to be in the right place. We had just one placement in inferior vena cava, but in hospital setting, not pre-hospital. And we had failures, foremost in obese patients. But probably for cardiac arrest patient, the cut down technique would add something to the procedure, to the security of the procedure. That's something we are talking about.
Do you mean it would add in a positive or in a negative way?
Yeah, in a positive. Yeah, to identify the right vessel. We are talking about patient with very high mortality. So
this comes back. At least sorry that I come back to you, but how many cut downs on a cadaver you have to do before you can do it pre-hospital on the patient?
The answer is I don't know yet. So we do not perform cadaver lab right now.
But Alice,
it really depends. What we do is we usually have one session on cadavers, and then for the people we are training, we do several cases together. And I wouldn't have a precise answer to give you on the number of cannulations to do, but it's usually at least 5, being 2 of us, and then 5 with a supervisor watching. But we wait until people are confident enough in doing it by themselves, because I mean, it's a question where you can't really just let people do it unless they are not sufficiently trained. But we haven't had the possibility of defining how many cut downs you need to do to be sufficiently trained.
Because do you have something for critical care physicians that do that in critical care? Do you have any kind of publication on how many training they have to do, or no, neither in critical care? We don't have it.
If I'm not wrong, there's a recent publication last year on the learning curve for Reboa. Well, I cannot recall the exact numbers, but as I reported on the first slides, the learning curve seems to be quite fast. So Brede from Norway trained this physician of the air ambulance with the interventionalist radiologists, which are more comfortable with chat and the wire and so on. So this is what we have done.
Yeah, a question to both of you, Carlo and Alice. As we say, the Repo it's needed more or less in hemorrhagic shock, in cardiac arrest, traumatic cardiac arrest. And ECLS, you're going to do it in every kind of cardiac arrest, but why don't we only learn the technique of Repo in pre-hospital so we can fit cardiac and non-cardiac arrest, and then go very quickly to the hospital and implement ECPR? What are the pitfalls? What are the things that will be go yes for this strategy, and what will be no for this strategy?
I think it would be interesting indeed to have most, if not all, pre-hospital physicians trained to do Reboa, to make sure that it can be delivered early, even as an alternative to epinephrine, as we mentioned earlier. And as you said, sort of make it an intermediate step between ALS and ECPR if needed. And clearly the idea is that I think it's easier to train people to do Reboa than to do ECPR, especially as intensive care physicians, for example, or pre-hospital emergency physicians are trained to put central lines in with ultrasound. So I think it would be interesting to train a lot of people to do Reboa, definitely.
Yeah. Anastasia?
Yes,
sorry. Yeah. No, I had just a comment, sorry, on ischemic complications that you mentioned earlier. What we actually found in the pig study that we did was that Reboa was only occluded for a couple of minutes. So there was actually no time for ischemic complications. And the idea was really to bring coronary perfusion up sufficiently so that defibrillation would work. So there was, I mean, at least in our experience, there were no ischemic complications, even less than with epinephrine. And we also showed that lactate levels were lower in the Reboa group.
yes.
I think we have one question that can fit in the discussion we already have is who would be the ideal candidates for Reboa? Pre-hospital, or are there any interference with other interventions? I think this is something that we'll already discuss if you want to address Dr. Mazzoli.
Well, the ideal patient, we are talking about trauma, non-traumatic, I guess. Okay.
It's not, it doesn't, asked specifically for non-trauma, generally.
Okay. Well, we talk about non-traumatic cardiac arrest. The answer is, I guess, a young patient has almost this the same for ECPR, I would say. So young patient, refractory cardiac arrest, maybe you have used the ultrasound to rule out like cardiac tamponade or rupture of an aortic, abdominal aortic aneurysm. So a non-traumatic patient, but which is bleeding too. And I would like to go back a bit, just 1 minute to discussion between Repo and the CPR. What if the Repo placement in pre-hospital setting by pre-hospital physician could prolong the 60 minutes time? Okay, so Ailso told us it's from the collapse to the ECMO running is 60 minutes. But if we at 20 minutes have a Repo placed into the aorta, maybe the 60 minutes could be 80 minutes, I don't know, perfusing the brain. Also, if we don't have a ROSC.
Quite interesting question for the future, yeah. Are there any plans, any studies that are planned in this regard or something? Do you know that?
Well, we have the Repo arrest ongoing, and the patients are excluded if they are a good candidate for ECPR. So that's one of the exclusion criteria, of course. Of course, there's this kind of dichotomy between the two techniques.
But you said, Carlo, that it can be a bridge for ECLS, maybe. How it's
maybe, yes.
How is it easy to switch between Repo and ECLS when you come to the hospital, when you arrive? Is it very easy or it's quite complex?
In skilled hands, I think it's very easy because you already have a shunt in the femoral arteries. So you just use the wire and of course the dilators, and you can place the cannula. The arterial cannula is already done. Then you have to choose the vein. Of course, you don't have the vein, but you have one less vessel to go. Okay.
There's a center in the States, at least one in San Diego, for example, for cardiac arrest patients in the ED. They systematically put an arterial line for cardiac arrest patients, and if the patients are in refractory cardiac arrest, then they switch the arterial sheath to the arterial cannula. So it is something that we could definitely think about, to sort of systematically have an arterial line to sort of titrate even epinephrine, or switch to Repo and then switch to ECPR. It's probably something that could be very interesting as well in the field of cardiac arrest. But once again, in trained hands as well, because it's not something that you could sort of decide to do if you haven't been trained.
I'm sorry, I have to take my role as timekeeper seriously now. It's a very interesting discussion. I think we could go on for hours.
Yeah.
But we have to switch topic. And it's my pleasure to introduce now the last speaker. Actually, he introduced himself already in the beginning. So it's Abdou Kouri from Besançon. I trained to spell this correctly.
You got it right.
And as you know, he is a senior consultant, emergency physician. And what he didn't say, he's the chair of the Medical Simulation Center there. And what you already said, but I want to repeat it, he's our president of our European Society of Emergency Medicine. By the way, we have the Congress soon in Berlin, but Abdou will say this at the end, I assume. And he will now talk about ventilation. So switch topic from blood pressure to ventilation. Abdou, it's yours.
Thank you very much, Willie. Thank you very much. And I want to thank again the ERC for this opportunity for a joint session. I think we have a good collaboration with ERC, and this something to be maintained and to be taken to the future and to the future activities. I just try to control my slides. Yeah. So I have quite disclosure for this talk. I have quite competing interest, and mainly with patent in devices in ventilation. And you're gonna see that I will present one of the devices I've worked on in inventing it about to ensure ventilation in cardiac arrest also. So as you saw, the systems, the new guidelines, the last year's guidelines have really worked on the systems and have really spoke about how the system can increase survival and how we should really the chain of survivors, and Alice and Carlo have spoken about it, how the chain of survival is really essential. Every chain, every link of the chain is really essential to have a survivor at the end of the road. And as you saw, there are lots of new things and new devices and new techniques that were put in place to really work on how to improve CPR and how to improve compressions and how to improve the heart function. But what about ventilation? What about ventilation? And when we see and look at the guidelines, 300 pages of optimizing CPR and everything. But what about ventilation by itself? Of course, it's said that we should ventilate. We should really ensure ventilation during the cardiac arrest as soon as possible. We have to deliver breaths approximately over 1 second. And we have absolutely to provide adequate volume while minimizing the risk of gastric inflation at a rate of 8 to 10 per minute. And of course, we should avoid hyperventilation. And so if you could look closely, are good things to do, but how we can achieve them and how the guidelines will tell us on how to achieve them. And we take a look exactly, and we see that the ongoing debate is still on how to control the airways and how to achieve and how to go to a definitive airway instead of saying and explaining to us how to really ventilate. They have the guidelines. We have to ventilate to 8 to 10 per minute, and you have to give a volume, but nothing to say how to achieve this exactly. And when you go to these guidelines, this last year's guidelines, they base themselves on 4 main studies. The first one was to compare between bag valve mask with a mask and with the ET tube. How do we do it and what's better? There's no difference in survivals. Another study, a randomized control study also, about the difference between inserting a supraglottic airway device or intubating the patient, the airways 2 trial, and also not big differences in survival. And the third one about if we insert laryngeal tube or we intubate the patient, what's the best for the patient? And once again, there's not really nothing about how to ventilate the patient correctly. And the last one was a retrospective study in hospital, and they asked themselves, what will happen if I intubate my patient? And surprisingly, when they intubate the patient, they decrease survival. So it's quite confusing data, but once again, that only speaking about how to achieve definitive airways and how to, let's say, control the airways in the patient, but nothing really on how to ventilate the patient and how to achieve good ventilation for the patient. Of course, we need to ventilate. And this is a study that was done a few months before the guidelines were released. And it was a retrospective studies. Idris and Chung and all their colleagues have looked to cardiac arrest patients, 560 cardiac arrest patients. They look on the impedancemetry that were delivered from the patches of the defibrillator. And they saw that here they are, your CPR going, and here are the insufflations. And they analyzes all this. And what they found out that when you ventilate the victim more than half of the time of your complete CPR, of your complete resuscitation, you increase survival by 2 times. You see, so you have to ventilate the patient more than 50% of the whole time of resuscitation. And when you do that, you increase survival. So it's really a very interesting study, although it's retrospective, but it's a really interesting study on the importance of ventilation in cardiac arrest patients. But the question is how to ventilate. We've done lots of studies, not only we in Besançon, but other teams also have done lots of studies. And all of us are let's say, are all okay with all of us to say that the ventilation performance is really weak. And so it's a review from the same group with Chang and Ahmed Idris, and saying that it's still a devastating situation. We still are not able to really improve us. Despite the fact that we are doing ECLS now, we are doing maybe Repo, we are really increasing our technique and skills in how to ensure circulation, as we have said, how to ensure circulation, but still we have limited evidence on how to do the best ventilation. The guidelines are really sure of that. We need to ventilate, we need to address ventilation as soon as possible, but how to do it exactly, we still lack some kind of tools to say how to do it exactly. And as I showed you on one of the studies, ventilation is really associated with good outcome. So we really need to explore this pathway. And of course, what they've asked in this review analysis, that we need new devices and strategies to guide out of hospital personnel, but not only, to do an optimal clinical performance in ventilation. And so we really need new devices to guide all the personnel that are doing ventilation, that are doing CPR, that are doing resuscitation, in order to have an optimal clinical performance for their patients. So we need some kind of ventilation feedback devices. And the few minutes I have remaining, I will speak about 3 of them. There are 3 on the market actually that we, to my knowledge, one of them coming from Korea. It was published 2 years ago. It's Amflow. And this is a device they have tested on different clinical settings, cardiac arrest, you see in the middle, but also IRDS, head trauma, and others. And when they show that this device will give you the rate, tell you when to ventilate, and it gives you tidal volume that you are insufflating to the patient. And you see on the left screen and the right side, in green, when you don't have any feedback, when you do it blindly, like we do it today or almost, when you do it blindly, you see that when you are according to tidal volume range, you're not really in the tidal volume range. And when you do it, and of the rate also, you are really disparate rate between 10 to 25 in case of IRDS, but also in case of cardiac arrest, when you see, it goes either from hypoventilation up to hyperventilation. When you use a feedback device, you see that in terms of rate, you're really sticking to the good rate of 10 per minute here, because the device was set for 10 per minute. And here you can also stick to the volume that you should give to the patient, around 400 to 600 milliliters, depending on the patients. So you can stick when you have a monitor like that. The pitfall of this kind of device, that they only tested it on a pulmonary simulator, on a chest simulator, on a lung simulator. It was like a model of intubation, because they've just connected the tube straight to the lung, so to the test lung. So it means that they do not have any kind of appreciation of the leakages, and especially that this kind of device do not measure the feedback from the patient, do not measure the volume that the patient is receiving, the tidal volume, and do not measure the leakages also. Another device developed by Zoll recently also, and similarity a bit between what they are doing with the CPR. You know that in the CPR, when you do CPR, you have now kind of feedback coming from the machine that will tell you that you are really doing good, or you are not doing good, you are doing fast or not fast, you are doing profound or not profound. That gives you some kind of feedback to adapt and to optimize your compressions. And this is a study they tested on 4 emergency medical technicians. They tell them to ventilate this time. This is a device. It's a sensor for ventilation. You put it on your mask, and then they ask them to ventilate the patient blindly first, and then they ask them to ventilate the patient with this device. This device also will tell you at what time you have to ventilate, so 8 to 10 per minute, and will tell you if you are in the good volume or not. So as whenever you have to ventilate, it will beep, so you ventilate, and you're doing your ventilate. This is your compressions, and this is your ventilation. So you see it's the same similarities, and this is your ventilation. When you have to ventilate, you ventilate, and then it will tell you, okay, this is the volume you have insufflated. And this is another study that they've done in Denmark on 64 EMTs, also blind and not blind. And you see that they really improve the ventilation rate, they really improve the ventilation volume, and at the same time, also the overall performance of the ventilation went up from 22% up to 75%. So it's really interesting when you are able to control what you are doing. It's much better, much interesting, and much better for the patient. The pitfall of this, once again, that you have also an indication on how you are ventilating. You have an indication on your frequency, you have an indication on your volume, but you don't have any indication, any feedback from the patient. You don't know if the patient is well receiving your 400 milliliters, or if the patient is really receiving your ventilation. We in my university, several years ago, have also started to work on this problematic. And you were one of the first in the world to speak about ventilation feedback devices up to in 2016 at that time. And we got some data with a device that we really wanted to provide the rescuer a visual feedback on the quality of the ventilation that was provided to the patient. And so it will enable high quality ventilation in all circumstances. And what's important is in all circumstances, regardless of the level of the experience of the user. So you will go to an ambulance driver, a BLS provider, a fire department rescuer, as much as an anesthesiologist or an emergency medicine physician. And this is how it looks like, a device. Also, it will give you indication on when to ventilate. So when you light up this device, you light up the device, it will ask you to want to ventilate a tall, a medium, or a short person, because you know that the ideal weight, the ideal volume, it's regarded to the ideal weight. So you just switch this, you put that. It will ask you also if you want to ventilate continuously or if you want to ventilate just intermittently 30 to 2, and then you put this, and the bar graph will help you ventilate the patient. It will give you indication on when to ventilate, and the bar graph will tell you if you are good, not good, insufficient, or excessive. This is when you test this. This is what on a test lung. This is usually what we are doing today blindly. When you are ventilating our cardiac arrest today, this is what happens in the patient. Let's say every spike here is one ventilation sequence, and you see that the volumes are unequal. You see the pressures are different, and you see much more that you are ventilating around 20 per minute. And when you use the device, you can see completely that you are really constant and the complete ventilation. All ventilation sequences are the same. So this is a study we published in Scandinavian Journal a few years ago. You see also the same other studies. When you use it blind, when you ventilate blindly, in terms of ventilation rate, in terms of volume, you are absolutely not in the guidelines. When you use the device, you are in the guidelines and you are completely in the ranges of what the guidelines are asking you. And you see our two different groups: the BLS group with ventilation with the mask, and the ALS group ventilating on the ET tube. And you see both of them, the experienced and non-experienced personnel, are really, when they ventilate blindly, are not really performant. So to conclude this, what about ventilation? It's an endless debate because the guidelines do not provide us the best way to ventilate. They give us how to, what should we do if we should intubate or not, but they don't give us how to really ensure ventilation. And this is the question. Intubation or not is not the question, ventilation is the question. And of course, we need to ventilate of a rate of 8 to 10, a volume of 400 to 600 milliliters, but unfortunately, we are not able to achieve them. That's why these new technologies will, I'm pretty sure in the future, will help us achieve all this. And I hope that these new technologies and these new ventilation feedback devices will go into the guidelines as we have a feedback on CPR also. And of course, and as we have said, I will invite you to Berlin to our conference. We're going to speak not only about cardiac arrest and ventilation, but about lots of other immersive medicine and disaster medicine actualities and interesting things and innovations. So thank you very much again.
Abdu, thank you very much. There are no questions in Slido as far as I can see. Are there any questions from the moderators or the other speakers?
So I have one question.
Please, Carlo.
Okay, when you use those devices, how can you define the percent of the volume you give delivered to the lungs or delivered to the esophagus? So the difference between BLS and the ALS team, I guess.
Yeah, it's a very good question. A very good question. When you intubate the patient globally, you can assess everything because you have in both sides, you have the measures. And if you have 400 milliliters going in and 400 milliliters going out, you're pretty sure that you really intubated the patient and there's no leakages. When it comes to the mask and you have a ventilating with the mask, you're not able to say if are leakages from the mask or things are going into the stomach. But what the device will do, it will alert you on saying you're not adequate in ventilation, you have leakages. So you're going to position yourself correctly to ventilate. Today, when you do it blindly, you don't know if you have leakages or no. You just ventilate. You see a bit of chest rise, of course, but you know that when the process of resuscitation go on, and the patient is cardiac arrest for several minutes, the compliance and the resistance of the patient will change, and the chest will need maybe more effort to see the rise. So you need to put more oxygen and more volumes to see this, and so you end up by hyperventilating. But again, to really know if it's in the stomach or it's leakages, you cannot know that so far unless you're intubated. So you have to just, when you see there are leakages, you just adapt yourself. You adjust your head once again, you tilt the head again, and you adjust your fingers on the mask, and you just redo it. So at least you have an indication that you are not doing good, which is not the case before when you don't have any device.
Thank you.
Okay, are there any more questions? If not,
Yeah,
well,
sorry,
Elise?
I had just a question on how would you suggest people do ventilation? Would you suggest that you do continuous ventilation during compressions, or would you stick to a 32 ratio? What are your thoughts on the question?
So far, what the guidelines are saying that when you intubate, you do continuous ventilation. And when you don't intubate, you do intermittent 30 compressions, 2 ventilations. I know that there are ongoing studies actually to compare these techniques and to even say that even with the mask, when we did intubate the patient, we can continue to provide continuous ventilation. These are studies ongoing on that. We don't have data yet, but as of today in the guidelines, they are really asking us to do intermittent ventilation when you are not intubated and you have an advanced airway. At this time, you do continuous ventilation. Yeah.
Okay, if there are no further questions, I would like to close the session. Thank you, the audience, for listening to us. Thank you, the ERC, for giving us the opportunity to have this joint session. And I'm sure for the future, we will have a fruitful collaboration for the congresses and others. And I would also like to thank the speakers, of course, for the great presentations. And I wish all of you a nice, continuous Congress for the ones who are at home on the screen and the ones are here on site. And maybe you can come to our booths here to further discuss the issues. So have a nice day.
Yeah, so we have
Thank you.
EUSEM booth
Thank you
also
very
here.
much.
Thank you very much.
Thank you. Bye.